Varicocele is an extremely common condition seen in men where the veins returning blood from the testis, called the gonadal veins or spermatic veins, can undergo enlargement. This happens because the blood flow in the vein, which is supposed to go up from the testis, due to certain defects in the vein, end up reversing in flow. This is called reflux, and because of the increased blood pooling within the veins, this leads to long-term damage in the testis and sometimes to the sperm quality, and in other patients it can cause pain and discomfort in the testicular area. Varicocele is diagnosed first through clinical examination, where a doctor would feel the area around the testis and look for any enlarged veins. And based on the need, they might order an ultrasound scan of the scrotal area along with a Doppler examination. In the Doppler examination, the size of the veins can be measured, as well as radiologists will examine the scrotum and see if there are enlarged veins on ultrasound, and whether these veins reverse their blood flow during deep breaths. Once the patient is diagnosed with a varicocele, it's usually categorized into grades, and patients with higher grades like grade 3, grade 4 might end up requiring treatment. So in this video, I want to explain when a patient with varicocele actually requires treatment. So does every patient having an ultrasound diagnosis of varicocele with a low grade, grade 1 or grade 2, require treatment? No, they don't. So according to guidelines, a varicocele needs to be only treated if it is first of all palpable, meaning it can be felt by the doctor during an examination, and it is also associated with either changes in the quality of the sperm or pain or any reduction in the testicular size. I would like to explain each of these in detail so that patients can better decide when they actually need treatment. When it comes to semen analysis, we need to look at least 2 reports that are done 3 to 4 weeks apart before considering any kind of treatment. And patients with infertility and palpable varicocele, or a varicocele that can be felt at touch, along with poor semen parameters on the semen analysis, will end up requiring treatment. Whereas a patient with a non-palpable varicocele or a varicocele that cannot be felt and only diagnosed on an ultrasound along with normal semen parameters will not require treatment. And when we look at other causes for treatment, for example, a person with a grade 3 or grade 4 varicocele and who is less than 25 to 30 years old will probably require treatment to prevent the varicocele from reducing the size of the testis. While this is less proven in adults over the age of 25, and going to the next set of patients that might require treatment, adolescents or young men and not adults with a grade 3 or grade 4 varicocele might require treatment to prevent the varicocele from affecting the size of the testis in the long term. And also in these men, if the varicocele is not treated, about 10 to 20% of them might have up to 20% or more reduction in the size of the testis on the side of the varicocele. When it comes to adults above the age of 25, the varicocele might affect the testicular volume much lesser. Only 5% of these patients might actually have an effect of the varicocele on the testicular volume if left untreated. Patients experiencing pain and discomfort in the testis once diagnosed with a varicocele, if it's either grade 3, grade 4 or it's felt, these patients can also opt for treatment, as treating a varicocele either through surgery or embolization gives almost 90 to 100% pain relief in the medium term. So what are the treatment options available for patients with a varicocele? You have either a surgical option where either incisions are made around the groin and the veins are closed, or you have non-surgical options like varicocele embolization, where an intervention radiologist using image guidance goes through a pinhole in the groin, and leaking or the veins that are refluxing are blocked with either some glue, foam, or certain small implants called coils, which are safely integrated into the body and do not cause any long-term effects. So the main advantage of procedures like embolization are they don't require any anesthesia, they don't require any cuts in the groin, and as the treatment is done through the veins, there is no chance or a zero chance of any damage to the arteries or the ingoing blood supply of the testis that can sometimes happen with surgery. And also there is almost a zero occurrence of fluid accumulation in the testis called a hydrocele, which is almost seen in 15% of men after surgery. And coming to the recurrence, while surgical patients can have about a 15% chance of needing a retreatment, patients undergoing varicocele embolization have 7% to 8% chance that they might require a second treatment. At RIVEA Vascular Institute, we use the ALIA IGS 740 image guided system, which has the AutoWrite AI-based radiation reduction tool, which allows us to use extremely low rates of fluoroscopic radiation while treating these patients with embolization. As many of these patients are young men, radiation reduction is extremely important in varicocele embolization, and using such advanced systems allows us to treat these patients with the lowest amount of radiation exposure. While the radiation given during this patient at our center is extremely safe and is unlikely to cause any long-term damage to the patients undergoing this therapy.